a certificate course in pain and palliative medicine from Pallium India, and also a national fellowship in palliative medicine from the Institute of Palliative Medicine, Calicut. He's also holding the fellowship in compassionate leadership. He has been working in palliative care since 6 years with special interest in integrating specialist palliative care. He is the faculty of many palliative care education programs, both online and on-site. And adding to his cap of feathers, he is a recipient of the prestigious Bruce Davis Gold Medal Award in the year 2022. So I warmly welcome you, Dr. Arjun Devarajan, for today's session and handing over it to you, sir.
Thank you, Sripriya, for the wonderful introduction. And good afternoon, everyone, and warm welcome to today's session. Sripriya, is my screen visible?
Yes, sir. It is perfect and good to go.
Thank you. Thank
Yes,
you.
sir.
So thank you. So let's start. So our session today would be on introduction about pain. Okay. So to start with the definition of pain, pain is considered as an unpleasant sensory and emotional experience. It's not just an sensory experience, it's also an emotional experience. And it's usually associated with or resembling that associated with an actual or potential tissue damage. So this is the definition that was given by the International Association for Study of Pain, the IASP, and which was in 2020 they added something, like it was expanded with addition of 6 keynotes and the etymology of the word pain.
वो हो रहा है स्टूडेंट तो काम तो मेरा हल्का है, कुछ काम नहीं होता मुझे बट
Prepare. Thank you. So the 6 key points they added was like pain is always a personal experience that is influenced to varying degrees of biological, psychological, and social factors. So pain is personal, more personal experience. It could vary from person to person. The way I experience pain by stepping on a needle won't be the same as one of you does that. So the experience of the pain, the level of pain would be different for both of us. So it's more of a person thing. So each person, the approach should be personalized. And pain and nociception are different phenomena. So, nociception means the sensation provided by of the pain, which is made by the activation of the stimuli. The stimuli acting on the nociceptors causes nociception. And pain, both are different. Pain cannot be influenced only on activity in symptom. So that's it. It's not just physical, it could be more. And through their life experiences, individuals learn the concept of pain. Again, it changes, depends upon the person. It could change from person to person. And although the pain usually serves as an adaptive role, it may have adverse effects on function and on social and psychological well-being. So what pain is a protective feature. You go near an noxious stimuli, it's more of a flight and run. You pull away from the noxious stimuli. So it's a more of a protective person. But it also has an adverse effect on function and functionality, social and psychological well-being, especially in case of patients suffering from chronic pain. And verbal description is only one of several behaviors to express pain. So just because I won't be able to tell you about my pain, or I am in a situation that I cannot talk to you about pain, doesn't mean I am in pain. I'm not in pain. I could be in pain, but unfortunately, I may not be able to express it or show any symptoms of that. So just because the patient doesn't speak that I have pain, doesn't mean that's it. So it's only verbal description of pain is only one of the behaviors to express pain. So always have concentration to those patients, look for non-verbal signs of pain, and assess and provide um, Sripi, is there audio issue? Is there any audio issue now?
You're audible for me, Dr. Arjun. So I was just trying to communicate to the participant who reported that. So I will just take it up on personal chat. You may
Thank you.
please continue.
Yes, thank you. So before continuing, let us talk about someone. Maybe someone who is a nearby you or a friend or someone. Maybe let's consider one of your neighbors. He is a working man, maybe a coolie worker. He lives with his wife, who is a homemaker, and two children, aged 10 and 4, who are going to school as of now. So he met with unfortunately, he met with a road traffic accident, and he ends up in maybe a paraplegic condition. Maybe spinal cord injury has happened. He's paraplegic as of now. He's bedbound. He's someone who you knows. So what are the expected issues he might be facing? I would like to hear from each and every one of you. So let me just break it down. Let's break it into physical issues. What are the physical issues he might be suffering from? He suddenly have a traumatic paraplegia. He's bedbound. So what we can expect? The suffering he might be having in physical terms.
He might have urinary and bowel incontinence or some problems with the urinary and bowel.
Thank you for the wonderful answer. Yes, urinary bowel incontinence could be one physical issue.
All of a sudden, his life has changed that he is not able to walk suddenly.
Sorry?
So psychologically, he must be very upset. That's out. All of a sudden, he is not able to walk.
Okay, yes, that's
Activities.
another good
Activities.
So that's another phase of issues he might be. Yes, exactly. Great thing that we were able to open up the psychological issues. He is unable to walk. He is unable to walk, and how that would affect him. Okay, more answers are coming in the chat box. The
Phantom limb pain.
He is traumatic paraplegic, not an amputee. So let me make it clear that phantom limb pain occurs when usually post amputation. So the person might feel like that the removed part, the amputated part is still there.
Bed sores.
Bed sores, great. Being bedridden. So more pain, yes, definitely. Traumatic spinal cord injury, there could be chance of pain. Being dependent on family members. Okay, we covered for the physical part. Let us think about the psychological part. One of things that you already mentioned, like difficulty or so unable to work, so being dependent on others. So depression is always a possibility. What are the psychological issues you might facing? Bowel bladder stones. What about anxiety? A feeling of being useless or dependent on others, feeling of helplessness, being a burden to the family, anxiety, great. Okay, so he's having physical issues, psychological issues, grief, anxiety, anger, great answers. What about the social issues? Socially, what are the issues or issues he might be having. Being confined to him, unable to move. Okay. So consider as a broadly as a social being. What are social deprivation, isolation? Yes, being dependent, unable to work, can't support his family. Good. Financial burden, being a financial burden. He would have been the breadwinner. Now he's unable to provide for his family. Stress-related disease, psychosomatic disorders, shame. The feeling of being a burden. What about the children? Loss of job, yes. Feeling neglected could be disturbed sexual life, yes. So that's something that we very less speak about, but it's always there. It should be addressed. Everyone, the sexual history of person should be addressed. Is the volume too low now? Or is it better? Are more of you facing issues with the audio?
No, Dr. Arjun, I don't think so. Nobody has told it.
No, more comments are coming. Please check the chat box. Okay, good. So, what about loss of his role? His role has been lost. Maybe he was the decision maker of the family, being the sole breadwinner. He would have been making decisions. What happens now? He's totally dependent on others. Um, like they may not consult him for taking a decision. So his role has changed. Maybe someone else has become. Maybe his wife has becoming the breadwinner, so she gets more important. So it changes. So all these issues could be there. What about the spiritual issues? Heard of spiritual issues? Like, uh, spirituality may not just include the religious, not just religious. It could be why God me. Yes, good. Why me, God, distrust on God. He might have lost the trust on God. He would have been someone who's been going daily to temple or church or regularly performing the pujas, the like the karma. He would have he didn't have any bad things, or at the same time he might be feeling guilty that he did something bad in the back time before time. So this is as a punishment for him. Loss of faith, hope. Why me? It's excellent answers, and thank you for the wonderful answers. Okay, so we just met a person who has been, who has recently had a traumatic paraplegia, uh, living with his wife and two children. So we, as healthcare professionals, would have seen his physical issues, but it is great that you all went to much beyond that and looked into multiple issues. So we are acknowledged he has physical issues, psychological issues, spiritual issues, and social issues. So the concept of pain, the total pain concept, which was put forward by Dane Cicely Saunders, was that pain has four factors, four components: the physical, psychological, social, and spiritual issues. So the total pain is contributed to by not just the physical issues, all these issues add on to his pain. And a good pain relief can be attained only if we tend to all the factors of pain. Just because you prescribe a tablet for this neuropathic pain, that might not be able to give him a satisfactory relief. We might even have to address other events. See, so few things that we said: physical, the comorbid conditions. There could be pain caused by the treatment or caused by the disease itself. Psychological anxiety, the fear of suffering, depression, past experience of illness, socially loss of role and social status, financial concerns, worries about future family, future of the children, being dependent on others even for activities of daily life. Spiritually, anger, faith, anger with God, loss of faith, loss. He might be lost in finding the reason to live. Why should I live anymore? What point should I look forward for? Fear of the unknown. So multiple issues could be there, vast variety. All these contribute to the pain of the patient. So whenever you are managing the patient, always look for other factors which might add on to his pain. So one more thing I want to ask, like, what all, as you are a friend or neighbor, you know this person, you know these many issues are there. What do you think as a palliative care professional or a healthcare professional? How can you involve, help him leave his pain? You all give sure, like put light into multiple issues he has been facing. So what all can we do for him? First would be empathetic listening, right? Listening would be helpful. Counseling definitely would be helpful for psychological issues, spiritual issues. The empathetic, most often the spiritual issues would be the questions which we may not be having answers to, which he also might be knowing. But and a person with an active listening would be more helpful for spending time with the person, finding out what is bothering him the most. Great. Provide vocational learning, great thinking. So the breadwinner is affected. So how the family would be going forward. So that's one of the major issues is facing the children studies, what the family is being providing for. What if we can provide a vocational training for him or his wife so that they can be independent on themselves. So children, maybe what if you could provide, you could yourself sponsor for one of the children's study education, or you could find some like-minded person as you from the society. Your friends could come in. They, if what if they can provide support for the education, rehabilitation. Definitely, we will try to rehabilitate him. Empowering with the appropriate community and finding yes, involving community, involving yes, the community, the friends, the neighbors, everyone to come to that look after helping him. Air mattress and maintaining hygiene to prevent infection. You might be able to provide, teach him how to take care of him. The nursing care, educate the family to look after him with minimal distress or addressing the issues he might be facing. Introducing him to support systems, support groups, systems, support groups might be another helpful thing we can do for him. So great job, guys. So I think we might be able to help him, help such patients in coming forward. So going forward, so inadequately treated pain remains a global public health concern. So the availability of analgesics or addressing even this issue of pain is very low in our system, not just in our country, in the whole world. A large number of patients suffering from pain are neglected. And it's very immoral and unethical to let any patient suffering pain, whatever the reason may be. We all have an equitable responsibility to manage the patient suffering. So as the ICMR guideline comes up, it's our responsibility to cure sometimes, relieve often, and always make the patient comfortable. So as the total pain concept, pain is not just a physical experience. It creates an emotional response. It has a social impact. It has a spiritual meaning. These dimensions will have either positive or negative impact on pain. It could be altering the pain sensation. And always remember, pain causes more pain, and all pain are real. So, as Robert Tycho said, what pain is, what the patient says pain is.
It is so Vicky.
Was that a question to me, or was an accidental? Okay, I'm moving forward. So, how many of you are having a trouble with pain? Is there anyone who is suffering from pain or long-term pain conditions? Is there anyone who is suffering from that? Who would like to share with us? Not compelling. Anybody with a issue? Yes. Cervical spondylosis. Sorry, someone else was saying?
Yeah, so you were asking about sharing experience of pain. So can I do it?
I'm sorry, not clear. You were asking something.
Sir, you were asking about the experience of pain. So can
Do
I
you
do
have an
that?
experience in pain, your own pain?
Oh, okay. One thing, it is about patient only. The patients, like I'm a pulmonologist, I used to treat cox spine patients, and usually they have dull aching but very boring type of pain. Patient gets so much depression because of this pain many a times. So
So, were you able to like now relate with what we discussed right now? Was it just physical pain was adding on to you, or if you had like someone has said she's suffering from cervical spondylosis pain, uh, so is it just physical, or is it adding on to more of your suffering, concern you psychologically or socially? Is the pain affecting you? Uh, Dr. Ansari has like, so I would like to hear from Dr. Ansari if you are okay. Dr. Kinjal has also said like yes, yes, ma'am. So what was the issues you faced? You were able to recognize other than the physical issues.
other issues than the physical experience of pain, they were like patient life. Like two of my patients get divorced because of that. So that was a very major social thing I experienced in my life. That because of persistent pain, even after the treatment, patient was not able to move out of the pain, and two of my patients get divorced. So that was the thing, just because of continuous complaints from the spouse.
So sad to hear. That's a very big social impact that has happened because of the pain the family had separated. Um, One other thing I want to discuss was that cancer pain is more often getting addressed, but less often non-cancer patients' pain will be addressed. So, how many of you have managed with non-cancer chronic pains? So, what are the conditions you expect a person with a non-cancer pain to come up with severe pain to you? What are the conditions you might be facing? You might have faced at least. Dr. Ansari said, like, I'm not able to give 100% your daily work. Yes, definitely.
Stroke, CVA.
Stroke, CVA, traumatic paraplegia, right? The severe
Migraine,
neuropathic pain. Migraine,
chronic
yes.
migraine.
Yes, migraine, phantom limping, mental fatigue, sciatica. What about pancreatitis? Uh, Vascular diseases, the peripheral occlusive vascular disease, a non-healing ulcer of few years, it might be but severely infected or severe pain, they might be not responding to normal medications. Bone metastasis, yes. So there are large number of conditions. Fibromyalgia, sickle cell anemia. Fibromyalgia is a nightmare. Endometriosis. So what, especially like, since you mentioned fibromyalgia, many often people complaining of this pain when they come to us. We give them pain medications, maybe up to tramadol, and we see them coming back to us in complaining of severe pain. And physically, or maybe an examination, you might not be able to find a explanation for that. So we usually brand them as a somatic disorder, somatic pain, which is he might be the wrong coming from them. That we don't agree to them. They have pain. Many often we put down our patients. This is the truth. Like always remember, all pains are relative. Whatever the patient says is the real pain. He might be having the pain issues. He might not be having the symptoms of you expect to have in a normal pain patient. Especially that's very evident with chronic pain patients. So do not turn them down. They might be in severe pain, and not just medications would be enough for their pain. You might have to intervene in other factors also. Fibromyalgia is commonly very associated with depression. So antidepressants would be a great help for them. We might have to look for other non-pharmacological management, physiotherapy, occupational therapy, exercises, stretchings, muscle stretchings, and these muscle relaxants could be there. Multiple drugs or multiple teams. Usually we might need involvement from other team members also. It's an interdisciplinary team should be involved. A physiotherapist would be definitely able to help. The nurse could be there. The counselor, the psychologist, a social worker, a volunteer. Everyone has a role. As pain is such a vast subject, so you might need help from every place you might get. Yes, we are getting more answers from non-cancer pain. Thank you. So moving forward, so there are certain factors which we see that pain, which can increase the pain of the patient. Could be fear, anxiety, anger, boredom, depression, discomfort, grief. Maybe some other symptoms like vomiting or breathlessness, which might be affecting him. Lack of sleep, and very often lack of understanding about the disease. So some things which we are saying to reduce the pain could be acceptance of the condition, reduction in anxiety, relaxation, a good sleep, happiness, joy, involving in certain things which might be giving him comfort, mending out the feelings, relief from other symptoms, explanation about the condition they are facing, putting them in the light rather than keeping them in the blinds away from what they are suffering. A little into the pathophysiology of pain. So the mechanism by which damaging stimulus in the body is perceived as painful by the brain is a very complex thing. So the complexity of the process itself from the nervous system, not being a hardware, it's always there's a plasticity. It can rewire itself, it can rechange itself, new routes can be taken. So it's very complex system. It can modify its function under different conditions. So the normal usual pathway of pain perception, the noxious stimuli comes to you. So there's a transaction where the peripheral nociceptor or the nerve endings get identifies the stimuli and start sending the sensation to that. So it goes through the first order neurons to the dorsal horn of spine, where a second order neuron carries over to the second order neuron, crosses the midline and ascends the spinal cord. So the spinal thalamic tract reaches the brain. So certain nerve areas of the brain get involved, and the descending modulation comes up. So this is I'm just giving a brief. I would like each and every one of you to go a thorough reading through this. These basics are very helpful for you to understand the pain and in managing your pain, the patient complaints to you. Have a thorough reading. So I'm just briefing through the condition. So a local injury or a noxious stimuli comes, there is almost all the place of the inflammatory mediators, and the nociceptors get stimulated. Nociceptors are the nerve endings, should be widely distributed, and the impulses are carried to dorsal on the spinal cord and reaches the thalamus, right spinal thalamic tract. Then thalamus to cerebral cortex and the limbic system, which is called as a tertiary. The pain is sensitized by the brain and comes back. So just a brief explanation. So one thing you have to know between the both nociception and pain. So nociception is just detection of the noxious stimuli by the nociceptors, followed by transduction, where there's a stimulation of the peripheral transmission to the sensory nervous information from peripheral to the brain. So this is more of a chemical changes or electrical changes which happens during the by the neurons. But pain is the product of a higher brain center processing. It entails an actual unpleasant emotional and sensory experience granted from nervous signals. So it is pain is not just stimulation of the nerves; it has also an emotional and other factors which are causing the pain. Certain areas where affecting pain. So a few more things you should know about imagining pain. Neuroplasticity is it's the capacity of the neurons and neural networks to change their connections and behavior in response to new information, or it could be sensor stimulation, development, damage, some stroke or injury, or in dysfunction. So it's the ability of the neurons to rewire themselves and form new tracks. So sense sensitization is an increase in excitability of a dorsal horn, so that the dorsal horn cells have lower threshold and response to low intensity stimuli, which are not usually painful. So one person I still remember is was a middle-aged man. He was a fisherman. He was living with his wife and three children. The elder daughter was married off. Second one was abroad. He was working abroad, and the younger one was just finished at +2, and she wanted to be a nurse. She was planning from that for a long time. So he was a fisherman. His wife was a daily wager. So he was a cleaning, housekeeping staff in a company. So what happened was he had a inguinal hernia. He underwent surgery, which is a very normal surgery, very easy, usual procedure, which happened in a very prime institute. On day 3, he started having pain in the site of inguinal hernia repair. So he went back to the surgeon. The surgeon admitted him, underwent a battery of investigations, the USG, CT, everything came back normal. So they tried with medications. He was not responding to the pain. The pain was severe. Then he was referred to the gastrosurgeon. He referred him to the neurologist, but the neurologist didn't find any wrong thing. So when he looked, he saw a IVDP, very mild situation, which was seen in the MRI, which was taken as part of the battery of investigation. He sent him to the orthopedician. Orthopedician tried to manage him. Not relief. He sent him back to the medical gastro. The medical gastro sent him to the new surgical gastro. Surgical gastro sent him to the general surgeon again. And he kept running from department to department. No one was able to give him a good relief of the pain. He started going from one hospital to another. By this time, you can really see the changes. What happened is the wife had to leave her job because they needed someone to take care of him throughout the day, because he's crying in pain at home, going from hospital to hospital. And the mother is also very elderly and was unable to help her alone. So the son had to leave his job and come back to the home, looking after to help him look after. By this time, the entire family dynamics broke. The major breadwinners lost their job. There was no proper breadwinner. It was only running on the second son's part-time jobs. And the younger daughter, who couldn't pursue a nursing profession, and she ended up in a technical ITI course, computer engineering related course, and she had to drop the team. And later we referred him to psychiatrist, and the psychiatrist also tried to manage, and then he referred to a pain physician who diagnosed it was a central sensitization. And he was given ketamine therapy, which worked for him, and he was put on medications called NMDA blockers. One the methadone he was on, and he's still able to do his active daily life. He's much of a pain-free since the incident. He's able to work now. His family is almost near normal right now. So this is something a central sensitization has caused them, how drastically it affected the family. So going forward, there are multiple types of pain. So each pain is different as each the perception by each of the persons. So you need to know what type of pain it is so that you can manage accordingly. Neuropathic pain may not be helpful. Medication for neuropathic pain may not be helpful for nociceptive pain and like way arounds. You might need to manage according to the patient, according to symptom, according to the pain of the patient, and that's the only way we can get a good satisfactory for the patient. So acute pain, it could be the present at the site of injury mediated by the nociceptors. Chronic pain, and could be related in conditions such as diabetes, diabetic neuropathy, severe arthritis, or tumor growth. So few of those conditions where pain is long term there. And somatic pain is generated by nociceptors in deep tissue. Visceral pain, it could be from a deep viscera like a gastrointestinal pain, could be from a gastric obstruction. All those things, visceral pain could be there. Neuropathic pain, it could be caused by damage to the nerves. It could be an injury or an obstruction, a tumor compressing or a mass compressing, something compressing the pain, your nerve can also cause the neuropathic pain. And a few things you should know is allodynia. Allodynia is a pain resulting from a harmless stimulus. So a stimulus which might not be causing pain could be causing pain in such a person affected by allodynia, where it is a severe neuropathic issue. So it could be similarly like the dress could be rubbing on the, just the dress rubbing on the area could generate pain for it. So that was a stimulus which might not be painful in a normal person, but it was causing pain. Hyperalgesia, that's exaggerated response to normal stimulus, a pain sensation which he might be responding much worse than a normal condition. A rapid pain, pain felt in an area other than the site of pain, which could, like a gastric issue showing pain in the shoulder, or a myocardial infarction pain, which could be radiating to the hand. So all this. Okay. So allodynia, hyperalgesia, and baseline pain. Such a normal pain that he might be suffering. It could be continuous or intermittent. Breakthrough pain is a person who might be having a baseline pain, but at times there might be severe surge in pain. We call that as a breakthrough pain. It could be much higher intensity. There could be some things which could precipitate the pain, like could be a movement or weight bearing, change in position. Depending on the condition, it could change. Or it can occur without any warning or any stimulus. It suddenly can also occur. It usually starts, lasts between few seconds to around 30 minutes or more. So incidental pain is when pain is a pain that is associated with precipitating factors like movement. End of dose pain is when the pain which might precipitate back when the effect of the medication's dose is removed. So that is one of the reasons why when we are providing analgesics or pain medication to a person, one of the principles that we always follow is to provide round-the-clock pain relief. That is, we need the patient to have pain relief throughout the day on 24 hours. So that depends on the pain medication. For example, if a patient gets good relief with paracetamol, considering the effective time period, the paracetamol gives pain relief is for 6 hours, the patient should get paracetamol every 6th hourly, so that for the next 24 hours, the patient remains pain-free. So in such a person, if the pain relief occurs before the next dosing, that we call as an end of dose pain. So it might last till the next dose of pain medication occurs. So coming to the assessment of pain, you need some skills, you need to train. You may not be successful at the first time. You might have to keep on working on that, develop your skill of history taking for assessing the pain. Always go with a structured approach. You need to have a structured approach to assess the pain. You need to assess the type of pain, what is causing the pain, and how you can manage with that history. And active listening is very important. You have to look for each and every You can call off the history that you provide. Excuse me, Supriya, one moment. I'll get back to him.
Yes, Dr. Arjun?
Sorry, I just one emergency. Just for a moment, kindly
Sure,
excuse me.
sure. No worries.
Carrying on. Yes. We need to have keen observation, active listening, listen to each and every point. You should find that what is causing this pain. You need to understand the history so that you can effectively manage. And a comprehensive pain assessment is the basis of a good pain management. Always start the patient as a new person, assess the patient's pain each and every visit properly, go through all the steps, and make sure you cover everything and it's recorded. So try to provide in a single language which they may be able to communicate with you. And as I said, every visits demand your attention for evaluation and treatment as a fresh and new as ever. Don't be judgmental. Go as a free-minded person. So few barriers which we might face could be under discrimination of pain due to deficiency in understanding basic principles of pain management by us. From our side, we might be under discriminating or we might be judgmental. Those things could be preventing from a proper assessment. And patient would be hesitant to report pain because the lack of their knowledge, or they might be afraid what the doctor might think, or would he think that I'm too much of complaining. So these are the common barriers we might face in practice. So one more thing that you should know is acute pain and chronic pain, difference between acute and chronic pain. So when a person comes to you, many often someone you see a patient with severe pain comes to you in pain. There might be multiple things you might be seeing. Like it could be a fight or flight, there'd be redness and sudden pain, with tachycardia, tachypnea, pupil could be dilated, he might be sweating. So that could indicate pain. But there will be also persons coming to you complaining of pain who might be sitting very calmly, but they might be saying they are having severe pain. He might not have any of these symptoms, but he would tell you that he has been having this pain for pretty long time. So that's it. The patients with chronic pain may not have the symptoms of that the normal acute pain presents, but they will be having severe pain. Do not discourage them. Look into them, then take the history. So the acute pain, it could be transient, while the chronic will be persistent and meaning to the patient. So the acute pain is usually positive. So it's most of a safety precaution. So you go near a burning fire, you pull out because of the pain. So that's a protective thing. But chronic pain, there is nothing for that. There is no useful purpose for a chronic pain. And acute pain is always a flight or fight. Chronic pain is more of vegetative. There could be pupillar dilatation, sweating, increased beating, heart rate could be there in acute pain. But more often, the chronic pain patients would be complaining of sleep disturbances, loss of appetite, unable to sleep. There is no unable to find pleasure in life, depressive symptoms, personality changes, constipation. That would be the complaint or the symptoms that we see in a chronic pain patient rather than the flight of fight things that we see in an acute pain patient. So don't ignore the patients who say pain but doesn't have a flight or fight syndrome. So pain history, as I said, there would be multiple barriers. It might be affecting the history, or you might be able, will not be helpful for you to take a proper history. So establishing a trusting relationship with the patient is very important. Always use open questions. Don't go for closed or leading questions. Ask for how is your pain, not as your pain has reduced, isn't it? Such questions should be avoided. The leading questions or closed questions should be avoided. Give them time. Ask his like when you ask how is his pain, that's a broader question. It's very open. He can answer whatever they like, way he like. We can say that the pain has been there, the pain is not leaving, he has pain and more at night, the pain is there when he tries to get up from sitting, or there is no much relief in the medication given. All these could come from in an open question and encourage him to talk. They might be reluctant to speak. You need the history, you need to help them, tell them that you need to listen to more, show that you are actively listening to them. They will open up to you. Only then you might be able to help. And watch for clues regarding pain. So, certain things that you might get from the history, and avoid jumping to conclusions. Never assume, always listen to them. Approach them as a fresh person, and your perspective should be different. So these are the basic things that you should assess as for pain in each and every person at every visit. So you can it's come as LDPQ or ST. So you always look for the location of the pain. You need to know what is causing the pain. So it's an abdominal pain or whatever it is, or it's the pain near the shoulder region, which could be a radiating pain. So that's why it indicate another the indication. Duration of pain is very important because you need to differentiate between acute and chronic pain. So you don't distress the patient. Palliating and provocating factors. So palliating factors are those which will help them relieve the pain. Some might be saying they have good relief with application of hot foundation or ice pack application. Sometimes they might be saying provocating factors which can worsen the pain. Maybe a movement, a change in position, those things could be indicative of history. The sensitive things which could be. So these might be able to help the change in lifestyle or activities of the patient. So someone with a metastatic bone cancer or which has affected his bones, his movement would be difficult. So that's a provocating factor for him. So he's mainly bedbound. He tries to walk to toilet. That is something he wants to do himself to have the feeling of independence. So he doesn't want to be in diaper. He wanted to walk or go to the toilet. Privacy is very important in bowel movements, and it is one of the leading causes of constipation. So, what if we can provide a wheelchair with a commode with which he can be taken to the toilet and he can have the privacy he's having? So, that is a modification you might be able to give him, which can reduce his pain, can improve his quality of life. So, that's one thing that you should know what is the palliating and provocating. And always ask for the quality of pain. Ask them what kind of pain are you feeling now. Some might be saying electric shock, like needle pricking, like stabbing, like something, a catching type of pain. So all those are important because you might know the type of pain from the system. The electric shocks, needle pricking, the numbness, all those things, or feeling hyposensation, all those could be more suggestive of neuropathic pain, while a catching type or aching type, localized pains could be more of a visceral or somatic pain. And radiation of the pain, radiation could also involve involvement of neuropathic pain, temporal factors more at night. Neuropathic pains tend to rise more at night. So that is why these questions are very important. And severity. Severity is important because you choose the pain medication based on the severity of the pain. Severity can be assessed by various scales. The best scale is ask the patient himself. So patient is the best person to talk about his pain. So there are multiple scales which we are coming up in coming time, and why we need to assess severity is also coming up. Then the impact on ADLs, activities of daily life, the feeding, using of toilet, continence, able to dress himself. All these things which are considered as activities of daily life, how the pain is affecting them, it should be known to you because you might need to provide suggestions to improve that. And the meaning of pain. So as said, it changes from person to person, assessor. So self-report is the best patient. I, as a person, is the best person to talk about my pain. No one else can describe my pain. So you ask the person, one thing is a normal scale where you ask the patient to score his pain out of 10, where 0 being no pain and 10 being the worst possible pain. You ask the patient to score his pain out of from 0 to 10, where 0 is no pain, 1 would be little higher, 2 might be higher than that, 3 more higher, then going up to 10, where 10 is the maximum number, highest pain possible. So you ask the pain from 1 to 4, it could be a mild, considered as a mild pain. 4 to 7, it could be a moderate pain. And above 7, it's considered as a severe pain. So why we classify this is coming up forward. So sometimes they might not be able to comprehend or may not be score up in 0 to 10. So we might have to go for more similar. We call that a canonical pain scale, where we ask them to say whether this pain is very severe, mild, or moderate. It is. So there are multiple scales available. This is a Wong-Baker scale where we use for children who might not be able to establish that. Or I think around above 4 years, we might be able to use Wong-Baker scales. And there are scales called flag scale, which we can use for very small children, which uses the facial expression, consolability, they cry, all those factors to assess the pain. That's called a flag scale. So multiple scales are available. So why the severity should be known is because you need to choose the pain medication based on the severity of the stone. WHO has put forward the analgesic ladder. So based on that, you can divide the pain into 3, the step 1, 2, and 3, which we give a mild pain, moderate pain, and severe pain. So from step 1, the patient might be complaining of mild pain. So the drugs we can use are non-opioids, which consists of the paracetamol and non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac, etc., along with adjuvants. So you will have most detailed sessions upcoming on these medications. So I'm not going to deep into that. Just giving a brief that adjuvants are a class of drugs which we might be using, which are not primarily pain medications but help with the pain. For example, amitriptyline or pregabalin is an anti-epileptic drug, but we can use it for neuropathic pain. So that considered as an adjunct. So patient comes with mild pain, you start them on mild non-opioids, so paracetamol and NSAIDs, along with or without the adjuncts. So there is no relief. If the patient is having a moderate pain, you go for step 2 opioids, which are known as the weak opioids, or recently known as opioids for moderate pain, like tramadol, codeine. So these might be issued for pains, patient complaining of mild, moderate to moderate pain. That's a step 2 medications. And always make sure non-opioids and adjuncts are given along with them. They are given, you can see that non-opioids and adjuncts are given all 3 steps to support the pain medication. So a patient comes with severe pain, not a mild or moderate, very severe pain, like a cancer patient or someone has a polytrauma. For him, a weak opioid or a non-opioid like a paracetamol won't be sufficient to reduce his pain. So he might need a strong opioid like morphine or fentanyl or methadone to relieve his pain. So hence the severity of the pain is the you utilize to choose which kind of medication you need to give for the patient. So when you're taking history, always introduce yourself clearly, maintain eye-to-eye contact, avoid off-familiarity, explaining what you have to do. Never promise them 100% pain relief. You are going to try with them to give you maximum, whatever possibility you will be able to do. We are not gods or we are not superpowers. We may not be relieving them of full pain, but we will assure them to try whatever we can do within our power to reduce his pain. And always try to summarize back and do not give false assurance and use simple language. So just a video. Sorry, I think the audio might not be there. Thank you, everyone. Thank you, everyone. Let us all work together to relieve the suffering, make as much as pain-free lives as we are able to provide. So that ends my session. Sripriya, are we going for the case presentation or should we have the discussion now?
Maybe we can take up some questions, maybe
Okay.
for 5-10 minutes, and then we can move ahead with the case.
So any point you would like to discuss?
Any questions, queries, any doubts?
So there's a question how to differentiate breakthrough pain and end of dose pain. So breakthrough pain that might be occurring in between itself, not just anytime it can happen. There might be or might not be a stimulant or a provocating factor for that. The patient might say a breakthrough pain, very high intensity pain. Otherwise, the patient would be having a good relief with the medication. So consider a patient on he is having morphine 5 milligram 4th hourly. An extra dose of pain medication, which to reduce the breakthrough pain. Hope I am clear. Dr. Ruby, are you clear with the explanation? Or anyone else want to ask?
Dr. Arjun, in the meantime, maybe we can take up the case.
Yes, I think that would be good.
Yeah, so in case you are having any more further queries, please do feel free to drop them in the chat box so that they also can be taken up along with the case discussion.
So be presenting the case.
So I'm sharing the screen of the case presentation. Dr. Lotha, if you may start.
Okay. Good evening, everyone. And today our case presentation to introduction of pain is about a 38 years old female who has been diagnosed with carcinoma of left breast. And her presenting complaint is she came with a complaint of left breast lump for the past 3 months. That was her only complaint. And then initially she had a breast lump for 3 months, but in the past 1 month, she started having mild pain and discomfort. And that is the reason why she came to our department. And then we examined, and then we found a breast lump on her left side. And then we did an FNSC from our hospital. And then she also had an axillary lymph node. So we took the FNSC from her axilla as well. And then it was a case of invasive ductal carcinoma with metastasis to left axilla. And in our setup, we don't have proper, advanced method of operation. So, and also the patient wished to go to some higher center where all the facilities are available. So she herself said that she will go to another city for her checkup. So after a week or so, she went to Guwahati And then out there also, they have diagnosed it as a case of invasive ductal carcinoma with metastasis to left axillary lymph node. And on 26th of September, that was after a month. In the same month, she underwent modified radical mastectomy. That is the removal of the whole breast along with the axillary tissue. And then she stayed in the hospital for about 2 weeks. So after completing the surgery, she was advised to go home. So she came back to Nagaland and then she came back to us again. So when she came back to us, at that time, she has not received any chemotherapy. And then when she came to our hospital, we saw the patient and then she was complaining of pain and discomfort in the post-operation site on her left breast. And then on further examination, we found that there was also some mild infection of the left post-operation site. So since she complained of a moderate amount of pain, and then she also complained that she could not sleep at night because of the pain, and then she was unable to perform her daily activities. So we told her to get admitted in the hospital for about 3 to 4 days, to which she agreed. And then so she was admitted for about 3 to 4 days in the hospital, mainly for the pain, but also to take care of our wound. Next slide, please. Can we go to the next slide? Yeah. And then on examination, her general condition was okay, except for the mild pallor. She was okay. Her BP and pulse were normal. Chest, CVS, and CNS was no abnormality detected, and there was no accurate diagnosis of fecal edema. Per abdomen, there was no organomegaly, and she was not complaining of. Her abdomen was soft. So on general examination, we could see only mild pallor. Yeah, please. And then we did some few investigation like CPC, serum electrolyte, to see whether she had sugar or not. And we did a viral markers also. And then it was all within the normal limit, except for the hemoglobin, which was 10.5 gram per DL. And also her total count was slightly on the higher side. And maybe that is because of the viral infection that was going on. Please. And during her stay in the hospital, we gave her, since we initially tried giving her a tablet, but she complained of nausea, vomiting, and all. And also her pain was not properly controlled with the tablet that we have given. So we gave her injection tramadol, 100 mg, every 8 hourly we gave her. And then paracetamol was also given. Along with that, 1000 mg as an infusion every 12 hourly. And then she has lots of appetite, and to prevent acute gastritis, we give injection Raplet 20 mg IV OT. And then we did daily dressing of the wound with betadine once in the morning and in the evening also. And after that, we applied topical mupirocin ointment. And to prevent the infection was actually mild infection only, but to prevent further secondary infection, we gave injection ceftriaxone with sulfentacin, 1.5 gram 12 hourly. So for about 3 days, she received all this treatment. And then on the 4th day, she was better. So we released her on the 4th day. Yeah, next, please. Now, coming to her psychological aspect, she is a 38 years old widow with 3 children. All her children are school going. The eldest was about 14 years old. And then another thing which we found out was her husband passed away recently. About 3 to 4 months back, her husband passed away due to cardiovascular accident in the same hospital, in our hospital only. He passed away. And then since the husband is the bread sole earner of the family, she had a lot of financial burden. And then she was surviving with her husband's pension. So the financial burden was also there with in her mind. And then for operation and to receive further treatment like chemotherapy and all, she has to travel to another city, which is about 9 to 10 hours away from her hometown. So from her hospital. So because of that, also she was quite worried that like every few months she has to travel a little far away from her hometown. So that was the psychological aspect that we have known from her. Next, please. So the main concern was actually the pain. The pain was the main reason why she came to our hospital. Of course, on examination, she had mild infection also. And another thing is the financial constraint that she was having. And like I said before, now she has to go for chemotherapy. So for that, she has to travel to another city. So that was her main concern. And in short, the summary is cardiac female with carcinoma of left breast with post-operation pain. Now our discussion point is now how do we deal with the problem faced by the patient overall, and then how do we now she has received already 8 cycles of chemotherapy. So I think in next few months she will receive radiotherapy also. Now, how do we prevent or what advices should we give to the patient to prevent any further infection? Because infection, because of that, she had the pain, and because of that, she has to come to our hospital. And then now at present, she's doing well, she's okay. But if there is such pain again in the future, what strong analgesic, because at home she cannot give an injection. So any other alternative strong medication that we can advise to her so that instead of coming to the hospital, she can take it from home. And how do we deal with her psychological issues as well? Thank you.
Thank you, Dr. Lata.
Yeah, yes, sir.
So first, I would like to hear from you how did you deal with the problems faced by this person?
Sir?
How did you deal with the persons faced by this person? How you were able to manage her?
Actually, the first problem concerning her was financial constraint when she first came. So, we asked her whether she had any health policy or insurance policy. And then she has told us that yes, they have a health policy cover that is provided by the government of about 20 lakhs. So, so with that thing, they had to process fast. So they went to another city only about a week. So we told her to process the health policy insurance provided by the government as soon as possible. So that is the advice that we have given to her.
Great. Solving the financial issues was very important.
Not completely solved, sir, but
yes,
at least some part of it. Yes, yes, sir.
Some partly you were able to. So we live in a country where 5.5 million people are at the verge of falling into below poverty line because of the health-related cost itself. So there are studies from 2017. So okay, so one thing he has done. So what others would like to add on to like how we could have what more could have done from this? No suggestions, no inputs. What if this person was seen by you? Would you like to do something extra add-on to that, whatever the good work Dr. Lotha and his team has done.
We would urge everyone to discuss their viewpoints. There
Okay,
is no
let's-
right and wrong here because we all are learning together. So please don't feel hesitance to disclose your points. Don't think whether it will be right or wrong.
Thank you, Stephen. Dr. Aniyama
Hello.
suggested that, okay, suffering from same burn. Okay, support groups is a good help system. So it could help, it could boost morale, and help psychological issues. And someone else was trying to speak up. Sorry, who was that?
Hi, I am Dr. Rahul. And
Yes.
regarding her pain, we can apply fentanyl patches if she's having a lot of pain.
There, I think I will have to contradict because I was too. I think from history it was told that she's having adequate relief with tramadol. Am I
Yeah.
correct, Dr. Lata?
Yes, sir.
Okay. So there she has good relief with parenteral tramadol. So I would rather, yes, low dose fentanyl would definitely would be helpful if you convert properly to the correct dose. Or also you can try with oral tramadol because oral tramadol is more potent than parenteral routes. So if she's having a good relief with tramadol parenterals, definitely there is high chance that she might have good relief with tramadol itself. So definitely there is always possibility you can go to low dose opioids also. So that is one thing that I want to speak. Step 2 of the WHO pain ladder is always there is a we can skip that stage because mainly the drugs like tramadol, codeine, having multiple issues are there. Some would be genetically they may not be able to process a medication, so they might not be helpful for them. There are high risk of reducing of the seizure potential. So such things, rather than going for a step 2 opioid, there is always a possibility where we can start with lower doses of step 3 opioids also. Okay, so fentanyl patch would have been if she could find a proper dose. And someone has suggested counseling sessions, great. Financial from NGOs, good. Tramadol could be tried. Yes, tramadol, okay, better side effect profile. How the kids are managed at home during a surgery? There's a question, Dr. Lotha.
Sir?
How kids were managed at home during a surgery?
Yes, by the relative.
By a relative.
Yes, by the patient's relative.
Okay. So manage anemia through nutrition and supplements, pain, okay, family members. So when you are concerned about dealing with such an issue, I would suggest you to break down the pain issues based on the total pain concept, break down into chart them accordingly, physical issues, psychological issues, spiritual issues, social issues. Then you might have a better picture of all the issues that you can, the patient is suffering from, and you might be able to help better. So that
Yes,
is
sir.
one way you can deal with. So looking at physical issues, the pain is there. So
Yes,
which
sir.
we are able to support with the medication. I understand you're also using topical local anesthetics for the pain.
No, that is antibiotics, sir.
Antibiotics, okay.
Yeah,
Then.
we have not used topical analgesic.
I thought you were using bupivacaine.
No, mupirocin.
Okay,
That is
sorry.
sir.
Okay. You are using bupivacaine, so I heard it as
Yes, sir.
bupivacaine. Sorry. So bupivacaine can be topically applied in painful wounds. It will be
Okay,
helpful.
sir.
So then, okay. So one more thing that I want to add was, when a patient comes with pain to you, always try to manage, correct the correctable causes. That's very important, which I wanted to talk after this person's discussion. So if there is a cause which is causing the pain, so whenever patient comes to you, assess for the cause of pain. Is that a manageable or is that a correctable thing? So here the wound infection would have been reason for a pain. So which is a correctable cause where they have properly applied an antibiotics. So leaving that correctable cause which is causing the pain would improve the pain. But
Okay,
what if it was a tumor, a brain tumor, causing pain by increasing the intracranial pressure? There we might not be have much to do. So that is not a correctable option. We might have to go to other options. But here we have a correctable options. Or maybe a fracture. Fracture good correction would be helpful into relief pain. So such correctable option should always be ruled out.
Okay, sir.
Okay. Then okay, state and some health benefits of proper channel. Able to telemedicine services, if possible, could be utilized. Great option. That's a good idea. Adjuncts for pain helpful for this patient. So that will depend on the pain medication. Pain, if it is a neuropathic pain, so then that would have been the same. Neuropathic agents, a tricyclic antidepressant or an antiepileptic drug would be having a role because many often these analgesics, which we commonly use opioids or weak opioids or NSAIDs, they may not be alone, may not be able to help for relieving the pain. So we have to treat the cause of the pain. If it's a neuropathic pain, we have to employ medications to manage that.
Okay, sir.
Yes, oral tramadol is more potent than parenteral route. Yes, it is. So how do we deal with problems? So we divided the issues. So grief reactions has been issued. So each and every issue, so social issues, we made vocational rehabilitation, providing educational support for the children. Those could have been explored. The social issues could be done. The psychological issues have been suggested for management, psychotherapy, counseling. Okay, so total pain of the patient is addressed. Then the second comes, sir. Yes, please.
6.
Sorry?
Her pain score is 6.
Okay.
So it comes under moderate pain.
Okay, it's moderate pain. Yes. So how can we prevent or advise us to give a further infection of the wound? So we can always suggest for proper dressing, proper hygiene, the use of medication, topical antibiotics. So one mupirocin may not be always affordable. One another affordable option would be metronidazole tablets, which we commonly use to crush and apply with an emollient. We commonly use that. It's very cheaper and easily available. So that's another method we can provide to provide the infection. If she's diabetic or some other comorbidities which might be worsening, we might have to go for that, the blood sugar control. All those things we can try to prevent another infection.
Sir, for metronidazole tablet,
yes.
Usually it comes in different. How much mg shall we apply at one time?
So what we do is we usually prepare, we crush a large number, around 30 or 50 tablets together, and we add equal amount of the petroleum jelly.
Okay, sir.
It's also suggested liquid paraffin can also be used, but petroleum jelly seems to stick for more time. So you mix with that, keep it for in a airtight container, we can apply it for dressing. I would suggest to keep it for at least 7 days. You can keep up to 7 days or make again.
Okay, 7 days. Okay, sir.
So those would be cheaper alternate rather than the ointment forms or gel forms which are available. If it's available, please use that.
Yes, it's available, sir.
Yes, please. So strong analgesic should be advised her to take home if she had pain again. So if she's having a good relief with step 2 medications, I would rather suggest to continue with the weaker opioids rather than going into strong analgesics at the time. But if she's having not a satisfactory relief or there are pain episodes, just not satisfactorily leaving her, we have to go for strong opioids. So our aim is always not to provide, we have never promised to give 100% pain relief. Our aim is always to give a satisfactory pain relief. So it will vary on the person. So for someone, a 6 by 10 would be satisfactory for them, but at the same time, someone 2 by 10 would be satisfactory. So we try to work up how much is possible to have a satisfactory relief for them. We don't expect to get 100% relief for each and every person. And it's always important to get them realistic expectations. We have to give them realistic ideas. Don't give false assurance that I will remove this pain. I will give you 0 by 10 pain after my treatment. We assure them that we will be providing as satisfactory as possible. Sometimes even that might not be possible. So we might have to change our goal of pain relief, that we might be able to provide pain-free during the sleep. At least the patient may be able to sleep without pain. Or sometimes the goal might be to keep them pain-free for during the rest, especially when someone with a very bad metastatic spinal cord tumor or a fracture. Spinal cord fracture might be even at rest if we can provide pain-free. That's one goal that we have to set. So it depends on the patient. We have to set the goals.
Yes, sir.
Okay. So when do we change WHO pain ladder score from 1 to 3? So 1 day or 2 days, how long do we wait to change? So that might depend on the medication we might need to use. So a patient comes with, we don't start from 1 and go to 2 and 3. So it depends on the patient. So when the patient comes to you, he complains of severe pain, you might have to start him on step 3 opioids, step 3 medications. But if the pain is very smaller, we go for step 1 medications. And we wait for like how much the duration to have a adequate half-life of the adequate dosage of medication in circulation. Like for opioids, it's around 48 hours. So you start a patient on morphine, you wait for you review the patient after 48 hours to assess the pain. If the patient is in good relief, we continue the dose, or if they are requiring multiple the SOS doses or the pain relief was not satisfactory, we will have to alter the change after 48 hours. And later it also we can change every 24 hours also. So it depends on the drug that can change. So you will have a more detailed idea when you have a session on upcoming sessions on pain medications.
Any other points, questions, suggestions? Yes, I see one.
So can we use patch opioids? Okay, so opioid transdermal patches. We have available buprenorphine and fentanyl are the ones commonly available. So what happens is patches are like a continuous infusion drug. So a specific dose is being continuously injected at the into the circulation. So when you stick a fentanyl patch of 25 microgram, every hour the patient receives 25 microgram from the patch into the circulation. So this will be beneficial only if we have a we have an adequate dose, the correct dose for relief. So as we said, the pain depends on the patient, and these medications, opioids, all these medications varies from person to person. So some might be having a relief at 5 milligram fourth hourly. At the same time, someone will be having relief at only 30 milligram. So it depends on the patient, the doses might vary. And ideally, it is always better to start with oral or parenteral medications, preferably oral, or if it's a hospitalized setting, if you're preferring parenteral, better that such ways, so that you get an adequate dose. You find a dose at which the patient has a satisfactory relief. So you titrate the dose so that you find the patient. If you I started a patient come to me, I started on 10 milligram fourth hourly morphine. And after 48 hours, maybe I saw that the patient is having good relief. He is not having any breakthrough pains or end of dose pains. He is having good relief between the 2 doses. Then we can suggest that that's an adequate dose for him. And also there is no adverse effects of medications are there. Toxic symptoms or adverse effects in there. So patient is having satisfactory relief with that dose. Then I can convert it to equivalent dose of the patch. Like if it was a morphine, I can convert it to equivalent dose of fentanyl. There are conversion tables available. You can convert this equivalent amount, then you can use the patch. Because once you stick on the patch, the dose is steady. You might not be able to increase or reduce the dose. So if the patient doesn't respond to 25 milligram fentanyl, you will not be able to change the dose immediately because it's a patch. So it's continuously going at the same dose. But with an oral or parenteral medication, we can hike the dose to give the patient adequate relief. I hope I cleared that. PCA pumps, patient control analysis pumps are used in certain centers. Yes, definitely it can be used for patients who require continuous infusion and severe pain. Are we allowed to undergo interventional pain procedure under palliative care like FlexFlex? I think there are issues in suggesting someone who should be trained in interventional pain should only be able to perform legally, as I believe. So you might have to undergo training in interventional pain for doing procedures like that. Dr. Rakesh, what background are you from? Yes, you're an anesthesiologist, and if you're trained in intervention pain, you definitely can go further. So we usually go for interventional pain when it is not responding to medications. So we try first level medication or whatever. If not even responding to strong opioids, patient is in severe pain, not responding to medications, or we have a line of medications. We try with the lidocaine or ketamine infusions. If even that is not working, we go for interventional pain. Sripya, have we passed the time? Sripya?
Yes, actually, I could see one more. Is that a comment from Dr. Rakesh? Some ceiling doses of opioid may. I believe that
Ceiling
is.
dose of opioid. Okay, I will just answer to that also. Sorry, Chippy. So ceiling dose of opioids are seen, especially drugs like buprenorphine, where it's a partial agonist and antagonist action comes. There would be a point where the opioids, due to the antagonist action of the same medication, we might have a ceiling dose. After beyond that point, higher doses may not be responding. So that's for selected medications like buprenorphine. Morphine, fentanyl, such medication doesn't have a ceiling effect. So there, the end dose would be whatever the dose is giving it adequate pain relief, or one of the adverse effects has come up, like a delirium or drowsiness.
So I think maybe we can call it a day then, Dr. Arjun.
I think yes, please.
Yeah.
We'll be open
Thank
for
you.
questions. I understand like there might be questions coming up more. So please send it to the WhatsApp group, and we will try to help you with the answers.
Yeah, thank you so much. Thank you so much, Dr. Arjun. I have been seeing you today also very busy with all the works at Pallium, and still you kindly agreed to enlighten us on this topic. Thank you so much for that. And thank you all the participants who interacted in the session. And with the promise that we will be meeting again in the next session with yet another important topic and yet another eminent speaker. This is Sripriya along with Dr. Arjun Devarajan signing off from the Tips Eco Hub. Till the next time we see, take care everyone. Be happy. Bye-bye.
Thank you, Shilpa. Thank you, everyone. Bye.
Thank you, sir.